Ultrasonography is characterized by the real-time imaging of planes within living soft tissue, which could not be visualized previously. Ultrasonography is painless, non-invasive, and cost-effective. Thanks to these advantages, ultrasonography has become the preferred modality for a wide range of abdominal screening examinations. Ultrasonography is especially effective in evaluations of the liver, gallbladder, pancreas, kidneys, and spleen. Recently, the digestive tract, such as the stomach and the intestines, has also been successfully visualized. During the examination, we use this probe to view the internal structures of the human body. The ultrasound image is displayed as brightness variations ranging from white to black. Internal tissues have inherent acoustic characteristics. The ultrasound beam is reflected at the interface between tissues of different acoustic characteristics. The greater the difference, the stronger the echo. This is displayed with brightness variations ranging from white to black. So, calculus, vascular walls, and the diaphragm are displayed as white because they return strong echoes. On the contrary, blood, bile, ascites, and other fluids are displayed as black because they have uniform acoustic characteristics and return no echo. We must analyze the ultrasound information to identify abnormalities. To do this, we must faithfully follow the given procedures based on anatomical knowledge. Otherwise, we cannot identify lesions. Let's discuss how to proceed with an ultrasound examination in clinical practice. Now we start an ultrasound examination. But, Christine, is there any precautions we must note?
Well, since we want to obtain clear images, we have to ask the patient not to eat before the examination. The stomach should be empty.
That's right. Then if the patient did eat, what would happen to the images? These images show the pancreas of a patient examined before and after a meal. The image obtained after a meal is unclear. This is because ultrasound is blocked by foods or intestinal gases and therefore cannot reach the target organ. The gallbladder discharges bile after a meal, then it shrinks. Therefore, the gallbladder wall appears thick and three-layered. This may result in an incorrect finding of cholecystitis. To avoid this, tell the patient not to eat after 9 p.m. on the day before the examination. The examination should be performed in the morning. If the patient is severely constipated, we may administer a laxative on the previous day. When the ultrasound examination is performed in conjunction with gastric fluoroscopy or endoscopy, ultrasonography must be performed first. This is important because the barium taken for examinations of the digestive tract coats the gastric and intestinal walls making ultrasonography impossible. If it is necessary to carry out an ultrasound examination in the afternoon, the patient can have a light breakfast, but must refrain from eating or drinking for at least 6 hours before the examination. Now, let's start the examination, but before that, we must ask the patient some questions. First of all, confirm that the patient is in fasting condition. Check if the patient experiences any subjective symptoms, and also if the patient has previously undergone an examination or a surgical operation. What should we do to ensure a successful examination? Well, we must follow given procedures and examine the entire region of interest. We must not concentrate on the first lesion we encounter, otherwise we may miss a second or a third lesion. By scanning carefully, we can discover hidden lesions. Right, let's start the examination. Christine, you'll examine Paul. Paul, you'll be the patient. First of all, have the patient lie supine on your right. Tell the patient to clasp his hands behind his head to widen the intercostal space. Then, arrange the operating panel so that you can examine the patient with minimum effort. Next, apply acoustic jelly to the epigastric area and spread it all over the abdomen. Jelly prevents air from entering between the skin and probe. When the examination is prolonged and the scanning room is dried, the jelly dries up and images become unclear. If this happens, apply jelly again. The sonographer holds the probe with her right hand, places it in close contact with the patient's skin, then starts the examination. Hold the probe firmly with your thumb, forefinger and middle finger. Place the ring finger and the little finger on the patient's skin to support the probe. Be sure to hold the probe firmly, as if it were part of your hand. Use the contact surface as the support point to change the angle of the probe. Then, move the probe slowly all over the target organ, from end to end. If the patient is rather obese, press the probe firmly against the skin. If the patient is lean, press the probe lightly on the skin. In both cases, if the probe corner is pushed down too forcefully against the ribs, it will cause pain to the patient. Let me explain briefly how images are displayed on the monitor. Ultrasound images displayed on the monitor are tomographic images obtained by slicing an object with an ultrasound beam. A plane has a front and a back surface. On the monitor, the front and back surfaces are reversed. Please bear this in mind. Therefore, sonographers must familiarize themselves with basic display procedures so that they can correlate images with the actual positions of organs. This mark is printed on one side of the probe grip. When you want to visualize a transverse plane, hold the probe with a mark on the right side. Then you can obtain the ultrasound image of the organ as viewed from the patient's feet. Therefore, the right side of the screen corresponds to the left side of the patient. I think this procedure is easy to understand for sonographers with the patient on their right. When visualizing a longitudinal plane, place the mark of the probe towards the patient's toes. Then, you can obtain an ultrasound image as viewed from the patient's right side. The right side of the screen corresponds to the patient's toe side. This procedure is also easy to understand.
Professor, if I can't find the direction during an examination, what should I do?
Don't worry. Lift either side of the probe or place a finger under the probe tip, and the corresponding side of the image will disappear. Thus, you can recognize the direction. Now, let me speak about basic scanning procedures for the abdomen.
There are roughly 8 scanning procedures for the abdomen. Let me show you the probe positions and the images for each scanning procedure. First, the left intercostal scan. Place the probe in close contact with the skin and slide it along a row of ribs in the intercostal space on the lateral chest wall near the back. Christine, find the position and place the probe. Yes, that way. This plane is usually used to observe the spleen and the left kidney. The spleen appears as a triangular shape reflecting uniform internal echoes. Part of the image on the right side of the screen is often missing due to air in the lungs. Observe the images if the size is normal, the margins are rounded, and if the vessels at the hilum of the spleen are dilated or twisted. In particular, the branching vessels at the hilum of the spleen usually measure less than 5 millimeters in diameter. If they are larger than 6 millimeters in diameter, there is a possibility that the portal pressure is increased. Measure the spleen. If A times B is more than 30 square centimeters, splenoma is present. Based on the degree of enlargement, various infectious diseases, blood dyscrasias, diffuse hepatic diseases, portal hypertension, or metabolic diseases are suspected. The spleen closely reflects the condition of the liver. A splenic abnormality suggests hepatic disease. This finding is helpful in evaluating the liver later. At times, a swollen lymphoma can be detected in the periphery of the hilum of the spleen. As you see, the spleen looks the largest in this plane. How about the plane located one rib beneath, towards the toes? The left kidney comes into view. The left kidney has an elliptical or broad bean shape. Generally, the parenchyma returns a low echo and the center returns a high echo. Observe the images carefully to see if the kidney's location, size, and shape are normal. Confirm that the echo level of the renal parenchyma is normal and the echo of the center is abnormal. The spleen and kidney are separated by a comparatively high echo area and are close together. However, if ascites is present, the spleen and kidney are farther apart and return no echo. Be careful not to miss this sign. Now, shall we evaluate cases using the left intercostal scan? This is a case of hydronephrosis. In a normal case, the renal pelvis cannot be visualized due to the echoes from the center. Hydronephrosis results in the retention of urine in the renal pelvis. Therefore, the renal pelvis appears as a no-echo area intervening the center. A calculus 15 millimeters across is seen at the renal pelvis and the origin of ureter in a no-echo area. Furthermore, another calculus 10 millimeters is seen in the inferior calyx. Next is the left subcostal margin scan. On this plane, Slide down the probe from the position used for left intercostal scanning to the left subcostal margin. Then view the left hepatic lobe. Push lightly on the probe, then tilt it gradually from the vertical position towards the head side. Then observe the entire left lobe. The third procedure is the longitudinal scan. First of all, align the long axis of the probe with the sagittal plane of the patient. Then, place the probe on the center of the epigastrium. On this plane, the left hepatic lobe is visualized. Check if the hepatic surface is flat, the hepatic margins form acute angles, the size of the left lobe is normal, and the hepatic parenchyma returns fine textured uniform echoes. When you want to obtain a clearer image, have the patient do abdominal breathing and have him breathe in and then hold his breath. Now, shall we discuss images obtained with the probe at this position? This is the clinical data of a case of cirrhosis. We see that the hepatic surface is irregular and the hepatic margins form obtuse angles. The echoes from the hepatic parenchyma are sparse and high. Now, move the probe from the center of the epigastrium slightly rightwards. This plane shows the longitudinal images of the abdominal aorta, the celiac artery bifurcating from the abdominal aorta, and the superior mesenteric artery, and also transverse images of the body of the pancreas, pancreatic duct, splenic vein, and stomach. Observe the size of the body of the pancreas, location and dilatation of the pancreatic duct, thickening of the gastric wall, and enlarged lymph nodes around the stomach. Move the probe from the median line slightly leftward in parallel. Then we can see the head and uncinate part of the pancreas. The echoes from the pancreas are usually too weak to be visualized clearly. Therefore, use the inferior vena cava and superior mesenteric vein as a reference to identify the head of the pancreas. Check for abnormalities in the size of the pancreas and in the overall echo level. Look for calcifications or tumors and dilatation of the pancreatic duct. Next is the transverse scan. First, position the probe at the epigastrium, turn it about 90 degrees counterclockwise, then scan the patient transversely. The inferior vena cava and superior mesenteric vein appear as short axial tomographic images in the transverse scan. On the abdominal wall side of the images, the transverse plane of the splenic vein looks like a tadpole. This rather large elliptical part of the head of the tadpole is the point where the splenic vein and the superior mesenteric vein merge. The pancreas is visualized as an elongated image curving towards the abdominal wall side of the splenic vein. To visualize the pancreas, press down on the probe rather forcefully, then tilt the probe tip slightly upward to expel gases from the stomach. However, if the patient is lean, do not press too hard on the probe because if the pancreas is compressed, the image becomes hard to see. Check if the pancreatic surface is smooth and flat, If there is a general or localized swelling, the pancreatic duct, which crosses the center of the pancreatic body, is normally displayed as two smooth white lines. The normal diameter of the pancreatic duct is 2 millimeters or less. If it exceeds 2 millimeters, it is dilated. Then check for a tumor in the head area. The main pancreatic duct often runs beneath and slightly posterior to the pancreatic parenchyma. Therefore, at times it is not visualized on the same plane as the largest part of the pancreas and the splenic vein. The swelled lymph nodes around the celiac artery and the common hepatic artery are often well visualized on the plane slightly above cross-section of the pancreas. In this patient, many swelled lymph nodes ranging from 8 millimeters to 20 millimeters across are seen. Next is the oblique scan. This procedure is used to visualize the tail of the pancreas. Place the probe along the elongation of the pancreas, then tilt it right and upward. Check for abnormalities in size, the presence of a tumor, different echo levels, and dilatation of the pancreatic duct. If you cannot obtain a clear pancreatic image with the patient in the supine position, raise the upper body, place his hands behind his back. This semi-recumbent position may be helpful in producing clear images. This is because when the patient raises his upper body, intragastric gases move towards the head and the liver moves down. This creates a path for the ultrasound beam. Next is the right subcostal margin scan. Use this procedure to observe the right hepatic lobe, gallbladder, bile duct, and right kidney. Scan by slowly sliding the probe along the costal margin and tilting it. Repeat the motion several times. When you want to obtain a clearer image, have the patient do abdominal breathing and have him breathe in and then hold his breath. This is because the liver is shifted below the costal margin and the acoustic window is formed. In the liver, the portal vein and the hepatic vein can be seen. The portal vein appears to be complexly bifurcated with edges. The hepatic vein is often not edged and runs radially, with the inferior vena cava as the center. The inferior vena cava is almost perpendicular to the portal vein. This procedure allows us to observe the region perfectly from the right hepatic lobe to the right kidney. Check for tumors in the liver, abnormalities in the parenchymal echo, and dilatation of the intrahepatic bile duct, the diameter of the hepatic vein, and the portal vein. On the border between the liver and right kidney, or Morrison's pouch, is where ascites tends to develop. Therefore, observe this region carefully. Compare the echo level of the hepatic and renal parenchyma. In a normal case, they return echoes with almost the same level. The fatty liver includes a brighter area produced by the echo from the hepatic parenchyma. This deviation in echo levels is referred to as hepatorenal contrast. This is a fatty liver of mild severity. The hepatic fine grains, the so-called bright liver. The deep region is a hypoechoic area because the echo is attenuated by fatty drops. The intrahepatic vessels are narrow and ambiguous. In terms of the hepatorenal contrast, the echo from the hepatic parenchyma is clearly stronger and positive. For differential diagnosis of the fatty liver, both the hepatorenal contrast and the hepatosplenic contrast should be positive. In the images of the left portal vein, characterized by its key shape, the left hepatic duct is seen on the horizontal abdominal wall side. Normally, the hepatic duct is smaller than 4 millimeters in diameter. If dilatation occurs, the hepatic duct appears to have the same lumen as the portal vein that runs in parallel. This finding is referred to as the parallel channel sign. If a calculus, carcinoma, or other occlusion develops in the inferior bile duct, the left hepatic duct is the first to become dilated. Therefore, it must be evaluated in depth to differentiate obstructive jaundice. The gallbladder has a pear shape and appears on the screen in the area extending leftward from the horizontal part of the portal vein. Assess the thickness of the gallbladder wall and check for the presence of foreign objects in the lumen. This is a gallbladder with a slightly thick wall. The wall is not thickened in the area from the cervix to the septum, but it is thickened by 3 millimeters to 4 millimeters in the area from the septum to the bottom, presenting a 3-layer structure. This is a case of gallstones. A gallstone about 4 millimeters across is seen at the cervix of a gallbladder. A gallstone reflects much ultrasound presenting a white image. A dark, no echo area appears behind a gallstone. This area is called an acoustic shadow, which is helpful for diagnosis of a gallstone. Some patients have a number of small stones, as shown in this image. This is a swollen gallbladder. Inside the gallbladder, you see a liquid surface-forming debris image. At the bottom of the gallbladder, you see a stone 3 centimeters across with the acoustic shadow. When a patient is told to change the position to the left lateral position with a probe kept in contact with the body surface, a gallstone is often seen falling in the gallbladder. This is effective information to differentiate a gallstone from a polyp in the gallbladder. This is a polyp in the gallbladder. On the wall of the gallbladder, a 3 by 5 millimeter polyp is seen. On the gallbladder bottom, you can see several polyps of 1 to 2 millimeters inside. If you cannot detect the gallbladder quickly, instruct your patient to do abdominal breathing. In a lean patient, the gallbladder may be located in the right side of the abdomen behind the front part of the right kidney, or in the pelvic cavity. In an obese patient, or a patient with a large amount of intestinal gas, this procedure may fail to detect the gallbladder. In this case, use the right intercostal scanning technique and scan the intercostal space between the 6th and 7th ribs, 1 or 2 ribs above the normal scan. That is to say, in a lean patient, the gallbladder is located lower than normally, while that of an obese patient is located higher. Bear this in mind, and you'll be able to detect the gallbladder rather quickly. Press firmly on the probe, then lift the probe tip in such a way that the probe surface will be in parallel with the abdominal wall surface. This scooping technique will allow you to observe the deep area of the right hepatic lobe and the hepatic dome adjacent to the diaphragm. Hepatoma is sometimes detected in this region. Next is the right hypochondriac oblique scan. With this procedure, the right hypochondrium is scanned so as to intersect the right costal margin. Instruct your patient to do abdominal breathing. If clear images cannot be obtained, have the patient lie in the lateral decubitus position. This procedure visualizes the trunk of the portal vein, the superior bile duct, and the inferior bile duct. Check if the trunk of the portal vein or the extrahepatic bile duct is dilated. If dilatation is detected, check for tumors or a strong echo area. The portal vein is normally 15 millimeters in diameter, the superior bile duct 8 millimeters, and the inferior bile duct 9 millimeters. If the diameters exceed these values, dilatation is suspected. However, the diameter of the bile duct differs from person to person, so the idea is to compare the diameter of the bile duct with that of the portal vein. If the diameter of the bile duct is almost the same as that of the portal vein, or appears larger, it is dilated. This finding is called shotgun sign. Now, the last is the right intercostal scan. This procedure is used mainly to observe the right hepatic lobe, gallbladder, and right hepatic duct. Slide the probe over the region from the 7th to the 9th ribs. The plane thus defined is nearly orthogonal to the right subcostal margin scan. Visualize the gallbladder with respect to the right branch of the portal vein and scan the region while tilting the probe slowly. Then, observe the gallbladder wall and lumen carefully. This procedure is especially suitable for evaluating the cervical part of the gallbladder. The right hepatic duct is visualized at the abdominal wall side along the right branch of the portal vein. Check for dilatation. Move the probe in a fan pattern. Slowly move to another intercostal space. Then, observe the right hepatic lobe and right kidney. This plane provides important information for evaluating the hepatorenal contrast or the presence of fluid in Morrison's pouch. Have you understood the basic procedures? It is up to the sonographer to determine the order in which the procedures are performed. Start by scanning the region which you can examine most easily. What is important is that you must scan each region thoroughly and must not miss any sign of disease. Images obtained on each plane should be recorded as hard copies, even if there is no abnormality. Even if the various scanning procedures we have discussed so far are followed strictly, correct evaluation cannot be done unless clear images are obtained. Then, what are the conditions required for good images? First of all, echoes from the shallow to deep regions must be represented with almost the same intensity. Second, the screen should be moderately bright, but neither too bright nor too dark. Finally, the vascular walls and gallbladder wall should be visualized clearly, and parenchymal structures should be uniformly displayed. To obtain images which meet these conditions, needless to say, it is very important to adjust the ultrasound system correctly. Now, shall we try to adjust the system? First, we arrange the equipment for examinations. Place your left hand near the gain knob, then arrange the operating panel so that you can reach any key quickly as needed. Next is the adjustment of the gain knob. This gain knob is used to control the overall strength of the echoes. You will operate this knob most frequently. If the gain is too high, noise or artifacts will appear. Then the images obtained have poor resolution. On the contrary, if gain is too low, important information may be obscured or deleted. So adjust the gain knob carefully depending on the patient's body habitus and region to be scanned. What about STC? Normally, set all sliding knobs at their centers. Then, all images from shallow to deep regions can be displayed with uniform brightness. However, depending on the patient's body habitus and the conditions, ultrasound waves may become significantly attenuated in deep regions. If this occurs, you must adjust the STC sliding knobs. For example, the echoes from a normal hepatic parenchyma should produce a uniform image. Adjust the STC knobs carefully. Incorrect settings may generate lesion-like images, leading to misdiagnosis. You can adjust the image on the monitor rather freely until you are satisfied. Sharp images with high contrast show great differences according to the strength of echoes, and the borders of organs or tumors are very apparent. This makes it very easy to perform measurements. Soft images show grayscale levels clearly. Therefore, it is very easy to differentiate a tumor with little echo variation. The purpose of the examination is to detect a lesion, and the image should be recorded. Without the record, you cannot assess changes in a lesion or reach post-operative prognosis. The ideal way of recording images is to record them when the screen displays the best possible image. This requires that the patient cooperate by holding his breath on your instructions. That is to say, when the region to be recorded is visualized, have your patient hold his breath, then press the freeze button quickly. You know that a dual display is possible. Therefore, you may freeze one screen and compare it with the image of another scanning plane. When recording an image, why not enter a body mark or comments? This will be very helpful when you review or explain your findings to other staff members. When all necessary information is entered on the screen, print the image. Well, the examination is completed. Paul, you can get up off the bed now. Tell me, how does it feel to be a patient?
Good.
Yeah? There you go. It's easy, you see. Yes. In conclusion, if you want to achieve a successful abdominal ultrasonographic examination, you must scan the regions correctly according to procedures based on anatomical knowledge. In addition, you need to be familiar with the system. Remember, fundamentals are always important.